All right, everyone. Thank you very much for joining the VCCC Monday Lunch Live webinar. I'm Nancy Baxter. I'm head of the Melbourne School of Population and Global Health. I'm also a colorectal cancer surgeon and health services researcher. First, I'd like to acknowledge the traditional custodians of the land on which I'm on today, and that is the lands of the Wurundjeri people, who have been custodians of the lands and waterways of this area of Australia for thousands and thousands of years and many generations. I also pay respects and acknowledge the traditional custodians of the lands of the presenters today as well. I would like to pay my respects to elders, both past and present, and extend that respect to other Indigenous Australians present online. Before we kick off today's program, there are a few housekeeping notes. First, today's event is being recorded and will be available on the VCCC Alliance Open Learning page, where you can also view previous webinars. If you have questions today for presenters, you can do this via the Zoom question and answer function. I'll be monitoring this, and so I'll be able to ask your questions to the presenters. We encourage you to submit your questions throughout the presentation, and we'll aim to answer them all at the end of the session. So first of all, I'd like to introduce our speakers. First, we have Professor Desmond Yip. Professor Yip is the Clinical Director of Medical Oncology at Canberra Hospital, Professor of the ANU Medical School, and Adjunct Professor at the University of Canberra. He's a practicing full-time medical oncologist with the main clinical and research interest in the area of gastrointestinal oncology and developmental therapeutics of cancer drugs. He also has a subspecialty interest in renal cell carcinoma and GI stromal tumors. Professor Yip has worked in collaboration with the John James Foundation, the Australian Government Department of Foreign Affairs and Trade, the Royal Australasian College of Physicians Pacific Islands Program, and doctors assisting in the South Pacific Islands to help develop cancer services in the Solomon Islands through in-country multidisciplinary missions, mentoring, supply of equipment, and facilitating staff training visits to Canberra. We also are joined by Dr. Andrew Soma. Dr. Soma, after graduating from Papua New Guinea and completing his residency, was posted to Gizo Hospital, the main referral hospital for the western province of the Solomon Islands. He's presently Oncology Registrar, National Referral Hospital, Honiara, and VCCC Master of Cancer Sciences students. So welcome to Professor Yip and Dr. Soma, who will be speaking today on establishing an oncology unit in the Solomon Islands.
Okay, I'd like to thank the VCCC for inviting me and Andrew to come and talk to you about the Solomon Islands oncology project that we've been running over the last 5 years. And just to give you a bit of background, so the Solomon Islands, South Pacific nation, is about 3 hours plane trip out from Brisbane, and it consists of archipelago of 350 islands and 9 provinces. So the population is over 600,000 people in the 2019 census there. And it's got a GDP of about $2,373 US per capita. So that puts it in a category of one of the least developed countries of the world. And that puts it below Papua New Guinea and Fiji. Its industries mainly fisheries, forestry, mining, crops, and tourism. And it does rely a lot on Australian foreign aid. So Australia's total foreign aid budget is about 4.3 billion projected for the 2021-22 year. And Solomon Islands has a dependency on the foreign aid budget of Australia. And the money that's allocated to Solomon Islands is $156 million for the same period. So I first became involved with healthcare in the Solomon Islands in 2016. We've got a local foundation in the Australian Capital Territory called the John James Foundation, and they run a Pacific Health program. The program's mainly been taking out surgical teams to the Solomon Islands to do operations on patients that they would otherwise not be able to do, and to help training the local surgeons there. And there was a request from the medical superintendent at that time for a scoping visit of the cancer services in the Solomons, and I volunteered to do that, and I accompanied one of the gynae oncology teams that were going out to so that one of the gynecological teams that were going out there to do gynecological surgery. And I made a visit there in September of that year. So this is our team. So it's several anaesthetists and surgeons who went over, and I accompanied them to do the scoping visit at the cancer services. So the challenges I found when I went there was that the hospital was actually quite old. The hospital was built by the Japanese in the World War II period, and it's basically the same structures from back then. There was a lack of CT scanner, there was no MRI, and there's no nuclear medicine facilities either. They didn't have radiation oncology. There was a very limited pathology service there, and often tests would not be available when reagents were in short supply or when they were run out. There was also limited drug supplies and also stock shortages, especially of the chemotherapy drugs which they were using there. There's no intensive care unit, so you couldn't manage intubated patients who got into trouble if they got sepsis. They had very slow internet speeds at the time, back in 2016, so calling things up on the internet in the hospital would be like the old modem speeds. You'd see the characters go across the screen really slowly, and often search engines would just time out. There was also the concentration of specialist services at the National Referral Hospital in Honiara. So although there are 350 islands, there were some the provincial hospitals, but most of the cancer services and all specialist services were actually at the National Referral Hospital on the main island of Guadalcanal. Cancer screening wasn't organised in a systematic way, and it was basically opportunistic. So these are some pictures of the National Referral Hospital. There was a hospital school there for some of the paediatric patients. This is the pathology department. The New Zealand government actually were good in providing some of the equipment, like new equipment, to allow for histopathology to occur. There was one histopathologist who was based at the National Referral Hospital. And this equipment had been delivered within the recent years and were waiting to be commissioned, be used properly. And there were registrars starting to be trained in that area. The New Zealand government were providing that training as well as mentoring. This was the medical imaging department. So it did have digital X-ray facilities. So they had a PAC system so you could get plain radiology. But as I mentioned before, there's no CT radiology. There was a mammogram machine which had been acquired due to fundraising by the First Lady's charity. And so they were able to do screening mammography, but as I said, that was opportunistic for patients who were coming to the hospital. The Solomon Islands also had a cancer registry. It collected incident data from the wards and also the pathology department, and it was staffed by 2 nurses and also 1 medical registrar. Often the diagnosis was just made clinically and there was no pathological confirmation because a lot of the pathology had to be done through Brisbane, and there was a lead time of sending the specimen out to Brisbane and then getting the result back a few weeks later. So the figures collected by this cancer registry were reported back to the Ministry of Health and also to the WHO, and that data back to 2009 at that time. The most common cancers they saw were cervical cancer, oral cancers, thyroid cancer and breast cancer. The cancer services in the Solomon Islands were not coordinated. As I mentioned before, there's no radiation facilities, radiation oncology facilities. The chemotherapy at the time was administered by the different teams, and they were given by the registrar staff. So they had medical team, pediatric team, gynecology team, and surgical teams which were administering the chemotherapy separately. And there wasn't any consistent use of personal protective equipment. So often, if there's a patient under the surgical team, the surgeons would just come out in their scrubs, administer the chemo, and can go back into the theatres again. And they were given in different ward areas around the hospital, not one cancer centre. So this was a typical case of breast cancer. It was often neglected, and patients would often present with metastatic disease or locally advanced disease, quite advanced cancers. These are the drugs which are on the Solomon Islands, the essential medicines formulary in 2016. So very old drugs that have been around for many years. Probably the range of drugs that we had in the 80s or early 90s if you were training in medical oncology in Australia. And they did have one biologic agent. They had imatinib. Imatinib was provided as, through a special funding scheme internationally by a charity. So they were able to treat patients with chronic myeloid leukemia using a targeted agent. And they had one hormonal agent, the tamoxifen. Otherwise, these are old drugs for treating a basic range of cancers. So part of the challenges of administering chemotherapy in the Solomon Islands at that time was the restricted drug formulary and also supply of the drugs. They didn't have a well-organized supply chain of making sure drugs were in stock, and they would only order drugs when patients presented and needed it. And so there was a lag time from getting the drugs ordered to getting them delivered and being able to administer it. There was a widespread clinician perception of adverse toxicity benefit ratio because they didn't have good supportive care medications. They didn't have 5-HT3 antagonists for emesis. So patients given chemotherapy, especially platinum-containing drugs or anthracyclines, would get a lot of vomiting. And therefore, clinicians were quite put off by the toxicity they would subject patients to if they were giving the chemotherapy. And there was a lack of trained chemotherapy nurses. So because it was different doctors administering the drugs, we didn't have a group of chemotherapy nurses who were trained to give the chemotherapy. And the chemotherapy was given in the ward areas, not in a specialized chemo unit. There were also cultural barriers to therapy. A lot of patients would opt for traditional treatments and not come in for treatment until cancers were quite advanced. There was no ICU support, so you had to be careful in terms of the sorts of treatments you were giving, especially because there was no hematopoietic growth factor support. If patients got febrile neutropenia and became septic, you weren't able to ventilate patients or give them inotropic support. And there wasn't much in the way of patient education materials. So there was a proposal at the time that I visited that they would attempt to centralize the chemotherapy service under the supervision of one physician. And they were going to train 2 of the nurses to administer the chemotherapy. And the registrar at the time, Andrew Soma, was going to be trained to be their medical oncologist. So these 3 staff were actually working for the cancer registry at the time. And then they wanted to introduce also specific protocols for the cytotoxic treatments. And so this picture here shows the proposed location of the chemotherapy unit, which was the old midwifery school. So after that visit, I'd made some proposals to the hospital at the time of what needed to be done. But we were also fortunate enough to get some funding from the John James Foundation to sponsor Andrew Soma to come over to Canberra for a visiting fellowship. And he was in our jurisdiction for about a month and was hosted by the Canberra Region Cancer Service. So during his time with us, we had attachments organised for the medical oncology, radiation oncology, hematology and palliative care departments. And he participated in the outpatient clinics, did ward rounds with us, attended the handover meetings and also the multidisciplinary meetings, and also went to Journal Club and saw the operations of our rapid assessment unit in the cancer centre. We also organised for him to have external placements with the anatomical pathology department, the oncology pharmacy, and also external imaging provider, Canberra Imaging Group, to learn about CT imaging. He was able to visit a number of the hospitals where we had cancer units within Canberra. So it was the Canberra Hospital, Calvary Hospital, and also the National Capital Private Hospital chemotherapy day units, and also went out to the hospice. So prior to Andrew leaving, he asked whether we might be able to get him some chemotherapy chairs. And it just happened that one of our chemotherapy units had been refurbished about a year previously. They moved into a new part of the hospital, and that's some old chairs which were still lying around in some disused suites in the hospital, which were about to be taken to the tip. And so I managed to retrieve these chairs, and by means of a shipping container that was being sent over by doctors assisting in Solomon Islands, an organisation based in Sydney, they were sending over a big shipping container containing an old decommissioned New South Wales ambulance, as well as a lot of surgical gear and stuff. We had these chairs included in that shipment. So subsequent to that, the following year in 2018, I was approached by the Royal Australasian College of Physicians they got an international partnerships office, and they were looking at expanding their activities in terms of providing aid by fellows in the South Pacific. And they had an existing memorandum of understanding with the University of Fiji, which is to provide a regional hub for education and training and also cooperation in the South Pacific. And they assisted in helping me put together a grant application to DFAT. And this is titled Building Capacity and Capability for the National Referral Hospital Oncology Unit staff. And we got together a team, a local team. So it was myself heading the team, as well as a very experienced oncology pharmacist, Beth Hua, who had previously trained at Peter Mac and also the Royal Marsden Hospital. And our clinical nurse specialist who ran our chemotherapy outpatient unit, Wendy Spencer, clinical hematologist Nalini Patti, who had some experience in doing some relief work in Sri Lanka, and also the manager of external partnerships at RSCP, Isabella Allen. Our aims of the visit, this mission, was to set up pharmacy and nursing chemotherapy guidelines and protocol development, staff training education, also delivery of some essential equipment. So their pumps, they had no infusion pumps, no electronic infusion pumps in the Solomon Islands, so I was using old drip sets manually. And we managed to get some decommissioned infusion pumps from Icon in Adelaide. These pumps had actually been refurbished the year before and had new batteries in them. So we took over 7 of those pumps and also took over some medical supplies, as they had a patient with advanced testicular cancer that they needed to be treated, and they didn't have bleomycin or etoposide on the schedule. So this was our first relief mission over to the Solomon Islands, and we did a number of lectures there. We did workshops individually with the nursing, pharmacy, and medical staff, and we did needs analysis with respect to skills. We had made visits to the pharmacy, the national medicine stores where they store their medications, the radiology department, anatomical pathology, and also the biochem labs. My colleague organised to do some marrow biopsies, and we're able to report on those. We did outpatient visits and ward consultations, and also did training sessions on PPE and order checking and workflows. We also had a meeting with the director of radiology at the time to help them progress a business case to the Ministry of Health there to acquire a CT scanner. So the National Referral Hospital Chemotherapy Unit was actually commissioned. So we got a surprise when we got there the first day, because they told us that they actually moved into the old midwifery school. So they're our chairs that we'd sent over, and they were ready to go with the treatment of patients over there. So we organised to treat the first patient with advanced testis cancer with the BEP protocol, and we also had been working with the pharmacist there to get ondansetron onto the national formulary, so able to cover that patient with ondansetron to stop them vomiting. We worked on finalisation of the oncology guidelines, Solomon Islands specific guidelines for administering chemotherapy and the chemotherapy protocols. We had organised for them to develop a consent form for chemotherapy and also treatment plans as well for the patients. And they were now focusing on patients with curable cancers. We had protocols on how to manage febrile neutropenia and tumor lysis. And we worked to get etoposide, bleomycin, dacarbazine, and vinblastine onto the formulary, because it would give us the ability to treat patients for cure who had lymphomas. And we also worked with the stores to try and ensure there were adequate supplies of the consumables, such as the drip sets and the personal protective equipment. So we made some recommendations about works to improve the functioning of the chemotherapy unit in terms of getting air conditioning there, and also installation of a cytotoxic isolator to prepare treatment with use of an isolation hood. And also some recommendations regarding key person risk and training staff for backfill if people had to be away. So one of our achievements was to formalise the Solomon Islands oncology guidelines. And we were able to upload that onto a therapeutic guidelines host application. So this is available on both Apple iOS and also Google apps. And the majority of the doctors there had smartphones, so they could actually have these guidelines and also other sorts of guidelines on their phones for access, and these could be updated. And at this point in time, I'd like to acknowledge the work of an AVI pharmacist, Emily Porrillo, who put a lot of work on the ground there before we arrived to get these guidelines in draft form for us to finalize and approve. We made a visit there in May of the following year, and we found that there were further works that had been done in the National Referral Hospital Oncology Unit. The caseload had increased, and Andrew Soma was able to present some data on what they were doing, and we were able to see that the skills of the staff were improved and that they were getting ward staff involved in being trained up to provide backfill as well. We introduced a new patient schema on what to do when a new patient was referred, how to work them up, what things to do to get them on treatment, and then how to arrange follow-up visits. And we also organised a scheduling diary system to allow patients to be staggered during the course of the day for their treatments and also their clinic appointments. We did some teaching around about chemotherapy complications and did some education lectures and outpatient consultations as well. So we were able to get the vinblastine, dacarbazine, bleomycin and etoposide onto the formulary. With those new drugs, we did further protocol development and were able to introduce complex protocols such as ABVD for lymphoma, curative treatment. And then we saw that also that their new medical ward had been commissioned, and they were able to increase their inpatient capacity for inpatient treatments. They had quite a new analyzer, which is now in use in biochemistry, and there were new analyzers which had also been provided in hematology. We looked at the needs analysis from the previous year, and also the recommendations that we made from our first visit and also my scoping visit. We've actually found that most of those have been achieved by the local staff in the Solomon Islands. This picture here is of our debrief of our team with the hospital staff and the executive. So in November of 2019, just pre-pandemic, we were lucky enough to get more funding from the John James Foundation, and we were able to organise for the two nurses, the oncology nurses, to come over for a visit to the Canberra hospital. And this is Stephen and Meltis here with my colleague Nalini Patti. And the framework that we used for that visit was a situational analysis done by a team who visited Fiji under the UICC in 2016. They produced a very nice document. If we're looking at doing work in the South Pacific, that forms a very good document on how to do nursing education. And that was led by a nurse, Winnie So, from the National University of Hong Kong. So we also used the EdCan nursing project, the Australian package from 2008. And when the nurses arrived, we also got them to do the EVQ education anti-neoplastic drug administration course. It was an online course. So during their visit, they were able to do an observership on the chemotherapy floor. They did ward attachments on our hematology and oncology wards. They worked with our nurse care coordinators and also did outpatient clinics with the doctors there. And the John James Foundation were also very, very kind to organise for them to be able to go to the COSA meeting in Adelaide. And it just turned out that there was one of the themes of COSA that year was global oncology, and their plenary session was on that topic. And I was able to secure a concurrent session, which I chaired during that meeting. And a plug for COSA this year, we've been able to secure another concurrent session at the meeting that will be virtual this year, COSA at the end of the year. So further progress in terms of in-country visits were suspended during the COVID pandemic last year. We had been planning to do another visit midway through the year, but all visits and deep fact missions were put on hold because of the pandemic. The undersea Coral Sea telecommunications cable was commissioned in that period and now allows for fast broadband internet, and we can do Zoom conferences now. We did further ongoing remote monitoring, so mentoring of the staff in the Solomon Islands. So every month I get 2 or 3 cases that I have to review. They're sent over by Andrew and his colleagues. getting difficult cases on what to do with these patients. And Andrew is also able to enroll in the Masters of Cancer Sciences program at the University of Melbourne, which he'll talk about in his talk. The chemotherapy isolator has been installed, but is yet to be commissioned. A CT scan is also, the case for it was accepted by the Ministry of Health and is due to be commissioned in 2022 at the National Referral Hospital. They've got a number of radiologists who've been sent overseas as registrars to train up in CT imaging. They're all back in country now. And so they're ready to go with the scanner once the scanner is commissioned. And Daisy, the doctors assisting in South Pacific Islands organisation, have been doing regular Zoom education meetings monthly with specialists in Australia and facilitating the training of the surgeons and the other specialists in the Solomon Islands and also other Pacific countries. We've got people participating from Fiji, Vanuatu, Kiribati and PNG. So just to acknowledge that our work there has been done with a number of different organisations, primarily being the John Jane Foundation, which supported us in a number of the visits and bringing over staff for their training in Canberra. The Canberra institutions, Canberra Region Cancer Services, Calvary Healthcare, National Capital Private Hospital, and also Icon Cancer Care. Daisy, we've been working closely with, the Royal Australian College of Physicians, who work in conjunction with the College of Surgeons, DFAT, and also Australian Volunteers International, who have provided pharmacy staff in Honiara at the times that we've been over to visit. Thank you for your attention.
Thank you very much. I'm just trying to get my video back on. There you go. Thank you for that fantastic presentation and really insightful in terms of your engagement with the Solomon Islands and the work we've done together. So we now have Dr. Andrew Soma who will present as well. So Dr. Soma.
Good afternoon, everybody. I'll just share my screen. Okay, good afternoon, everybody. I'm Andrew Soma from the Solomon Islands. I'm the Oncology Registrar at the National Referral Hospital in Honiara and the only oncology doctor here. I'm just going to talk on global oncology and the challenges of managing cancer here in the Solomon Islands. Okay, I think Desmond mentioned a bit about the background, which is much the same as what I'm just going to say here. 75% of our population live in rural areas and villages. Most of them are subsistence farmers, and there is no regular income. Just from our data, and in Solomon Islands, cancer kills about 1 person every day, and of course, it's increasing every year. Just a bit on cancer incidences in the Solomons. Obviously, it's increasing. This is some of our data from 2010 to 2017. Yeah, and just a bit of the background of the oncology unit. Initially, the cancer unit started as just a registry in 2008. Foundation started by the First Lady Group, as mentioned by Prof. Yip. And cancer data is collected, only the cancer data is collected in the registry. And I think Prof. Desmond Yip mentioned about the scoping done by him in 2016. So, excuse me. And in 2017, the NRH's executive passed that there should be a separate oncology unit in 2017 from all the scoping visits made by Professor Desmond Yip. And of course, in 2017, I went and had an attachment in Canberra, and renovations of the midwifery classroom has also been going on from 2017 to 2018. However, it was quite incomplete. And from their visit in 2018, the oncology PIP team, which consists of Prof. Desmond Yip and his team, came also in time to start the use of the new chemotherapy unit. And in 2019 December, the 2 oncology nurses went also for the observatory attachment at the Canberra Hospital Cancer Center. And initially, as Prof. Yip has mentioned, the treatment usually done by different departments. And as you can see in the picture, the room where they do the chemotherapy is quite not a very hygienic place. It's also the same room that's been dressed wounds from diabetic wounds and all that. So after the diabetic wound dress their sores, then the chemotherapy patient would go in and we administer the chemotherapy in this. It is not well centralized, and cancer patients are not very well taken care of initially. So the treatment we have here are just surgery, chemotherapy, and hormonal therapy, which only tamoxifen we are given. Just a bit about some of our cancers, common cancers here in the Solomons. As our cancer registry is hospital-based and not population-based. So from the data here, our most common one is cervical cancer, which is top of the list, followed by breast cancer and thyroid cancers and lymphomas. And also we also have mouth cancers too as a common one. So these are the most common cancers according to our data, but cervical and breast being always the first and second. Just a bit on our chemotherapy cases and sessions. We've just begun the chemotherapy unit in about September 2018. So we had a whole year of 2019 and 20 as a fully functional unit. So we as you can see from the table, the cases have increased. We have a total of 39 new cases who attended the chemotherapy unit in 2019 and 53 in 2020. So there's obviously an increase in patients who received chemotherapy at our unit. Most common cases who receive chemotherapy here at the unit are first and the most are breast with the AC protocol. And then we have the oral cancers, methotrexate protocol, and the non-Hodgkin lymphomas. And fourth is head and neck cancers. So these are the 4 most common types of cancer and treatment we give at our cancer unit. There are others which I did not include here, but these are the 4 most common. Some developments. Just about my attachment at the Regional Cancer Center in Canberra. I have never seen an oncology unit before, even from my undergraduate studies in PNG. So it was a very big eye opener for me, and I've learned a lot. And just by it's quite a very advanced cancer institute. But while I was there, I can slowly pick out what is doable in our setting here in the Solomons. Therefore, we, with the assistance of Professor Desmond Yip, we try to look for the chemotherapy chairs and infusion pumps. So I thought that with these two things, we can even start our small chemotherapy unit. So that's where that one started. So we managed to obtain 4 chemotherapy chairs and 7 infusion pumps. Later on, when they came in for the visit, they brought also a good number of consumables with them, which we managed to get it into the pharmacy consumables for purchase from our normal pharmacy orders. And yes, and also the most important thing as well is the formation of the oncology guidelines, which I think Professor Desmond have talked about. So version 1 was done. Now we've moved to version 2, was already approved by the National Medicine and Therapeutic Committee here in the Solomons, I think September last year, but it's still not embedded into the app. So they're working on it at the moment. So that, I see on the picture, that's our treatment protocol, which deals with the cytotoxic handling and also updated to version 2 end of last year. There are also other cancers we treat, but with a consultation with our mentors, Professor Yip and Dr. Nalini, and I will also mention Alison from the Regional Cancer Center in Canberra. So some of the cancers which are not in the protocol, but we have the medications available. We also consult them so that we can also treat them as well, even though they're not in the protocol. So our staff, we have 1 doctor, myself, and initially there were 2 nurses, but when the other 2 nurses went for training in Canberra in the end of 2019, they allocated a nurse to stay with me to help me run the place. But then when they came back, she stayed for good, so which is a bonus for the unit. So yeah, our main functions at the oncology unit here is firstly and initially was cancer registration, and we also do the chemotherapy manufacturing, mixing, and administration of drugs, and we also see the cancer patient referrals from other departments in the hospital. I also run the consultation clinics, which is supposed to be Tuesday and Thursday afternoons, but practically it's almost every day because patients are sent in as soon as the other doctors see them. So we also do ward rounds to some of our patients who get admitted in the wards. So our patients, the medical ones, they get admitted in the medical ward, surgical ones in the surgical wards, the gynae ones in the gynae ward. So we actually don't have an oncology ward. We do the rounds on the other wards where our patients are. And then, yeah, we do also a lot of awareness and education, which is, I think that's one of the cheapest way that we can try to reduce cancer in the Solomons. And also we do also MDM meetings, mostly with the surgical team and the radiology team. But you know, it's been up and down, so not really stable at the moment. So concerning our cancer registration, we start, as the history, we started in 2008. We started using CanReg 4, the program for registering cancer cases, in 2012, but the data was lost due to our computer crashed. However, they're still collecting the data. In March of last year, technical officer from WHO came and trained us for CanReg 5, how to enter the data for cancer patients. But only the first part done, and just after the first session, there was this COVID-19 pandemic, so there was a halt. So concerning the data currently, our data is not really up to date for the last 2 years. This is because of the clinical work. So the nurses are more focused on the clinical work in the chemotherapy unit, so that it's quite hard for them to, by the time they finish, it's already evening. We couldn't really catch up on the entering of the data. So most of the data we can see is up to 2018. And so, yeah. So that's one of our also challenges we are facing at the moment for the data registration. Yeah, we actually were, the renovation of the unit was not complete, and there was a lot of constraints on money, and they were not focusing on us. So we tried a different way of trying to complete the renovation for the unit. So we got Gladys, one of our pharmacists, who just, she also a graduate from Melbourne University, pharmacy. And she also assists us with our drugs for chemotherapy for our patients. So we asked her if she could participate in the Miss Solomon contest, so that she can be a platform to get donation and charity to help the cancer unit. So she agreed, and she went to the contest, and eventually she actually won. So she became the Miss Solomon. So from her platform, we managed to get good donations from business houses and people around the country. So that's what really stepped us up in renovating our cancer unit. But not only that, we also do go around doing awareness, especially for cervical and breast cancers, as they are the two most top cancers in our country. So that was one of our big blessings. So just some of the photos showing volunteers giving a hand at renovating our cancer unit. So there was a bit of transformation there. So on the left, you see the old room, and on the right is what it looks like now from all the renovations and the charity work. So yeah, there's also donations. There was also they donated also computers and laptops for our unit, which is important in for the cancer registry for entering of data, and all other stuff as well, beams, mattresses, even the aircon for the room is donated. So for the chemotherapy room and the mixing room, and including TV and all entertainment system for our patients and wheelchairs. So it was a big leap for us. And these are some pictures of where we go out to do our awareness. We also do a lot of awareness on our national radio station, SIBC. So we do mostly on cervical, breast cancers, and even other cancers as well, mouth, thyroid. So they recorded us on the radio, and it keeps, even today I can hear myself speaking from one of my recordings in more than a year ago. So we also do a bit of cervical and breast screening in the country. For cervical screening, we do pap smears, and VIA also are done in certain clinics around Honiara, and also in the provincial hospitals, it's also done. But yeah, it's opportunistic. So whoever wants to come for screening, they will provide it for them. Breast screening is also done with a mammogram. However, the mammogram machine is down for maybe 2 years now. Somebody is supposed to come and fix it from Australia, but due to this COVID pandemic, they still cannot come and fix it. So it's still idle there. However, after we did a lot of awareness, there we also have a lot of people, women coming in, actually straight into the oncology unit to do screening. And then we realized that we might need a breast clinic to cater for them. But we don't turn them away. We facilitate their screening. So we examine them, organize the ultrasound scans, find needle aspiration, and also refer them to surgeons for biopsy and even mastectomies. Concerning HPV and hepatitis, HPV has been piloted in several schools, I think 2 years ago, but I think it has stopped. So they vaccinated the 9 to 15-year-old girls from quite a number of schools around the country, but not all. And I think it has stopped for a while now. But yeah, we're still going after it. It's an important thing to continue, as cancer of the cervix is the #1 cancer here in the Solomon Islands. Hepatitis B vaccines are usually given in birth in all hospitals and all clinics around the country. So usually babies who are born in clinics, they usually have it. Smoking, alcohol, and betel nut chewing awareness. We have law on smoking. So age of smoking, you cannot smoke in public places, and also alcohol. Alcohol, 18 and over before you can take alcohol. However, there is no law on betel nut chewing yet, although this is one of the main causes for mouth cancer here in the Solomon Islands. We still don't have a law on that yet. Something we need to look into. Awareness on this is mostly done by also health promotion team at the Ministry of Health, but oncology team is also doing this on air, and we also have asked the oncology staff going out and doing awareness in each different groups, church groups, company groups, and other small groups as well. So as you can see, this is our chemotherapy manufacturing cupboard, which it's already set, but then it's still yet to be properly installed or commissioned. The person who's supposed to come and do it because of this pandemic has not come in yet, so we haven't used it yet. So we're still currently mixing chemotherapy on the trolley as well. So we're still doing it old-fashioned way. What's some of the challenges? Firstly, I would say it's human resource. We need a nurse or a personnel to be employed to concentrate only on the cancer registry, collecting the data and entering into the candidate program. Currently, we are liaising with a WHO office in Fiji to look into that side of things. So we're still communicating with him. How can we find somebody to do that stuff, the recording data. And also, this is another big issue. I think we need a second doctor to join myself here, because the workload is increasing, and especially when I'm doing this master's course, it's also time demanding. So that I can have some, a few hours off in the daytime doing the reading and stuff while somebody else is looking after the place. And of course, yeah, we need to update our cancer data and registry. The isolatory room needs the installation, but I think we have to wait till the pandemic is over, I guess. Another thing is, I think only 3 of our infusion pumps are now working. 4 of them are broken down, so we need to look into this as well. So if there's more than 3 people taking chemotherapy in a day, then we usually run the others manually. Shortages and delays in supplies. This is quite a big problem as well in the country, and it causes a lot of recurrences, delay in treatment starts, and also actually it kills some of our patients as well. The last shortage delay we had was like 2 months. So, if you've been receiving chemotherapy and you stop for 2 months, it's not very good before you start again, somewhere in the middle of the cycles. Of course, no CT scan, but next year is looking looks promising for next year. No radiotherapy, and also mammogram machine is down more than 2 years, need to be fixed as well. But the pandemic is also causing problems on that. And this is another of the big challenges, traditional herbal and witchcraft medicine causing late presentations, as not only the 75% of the population who rural areas go for traditional, even people who are educated, nurses, doctors, they also go for traditional herbal medicine initially before they go for the modern day medicine. So it's quite a big problem, which ends up in a lot of late presentations. Or not only initially, but somewhere along the way they stop chemotherapy and go to look for traditional medicine. And yeah, of course, COVID-19 diverts a lot of focus from the normal services. So there's a bit of neglect on that as well. So yeah, the CT scan update. I've had a word with the head of department for the imaging, and he assured me that by February next year it should be functional. So it's a good news for the oncology unit and the country as a whole. Yep. Yeah, I'm currently doing the Master of Science online course in Melbourne University. And yes, again, thanks to, it's sponsored by the John James Foundation. So they are the ones who are sponsoring my tuition fee there. So they've given me a chance to do the course. It's been very, I'm currently in the third term. I've done the Cancer Foundation, Cancer Diagnostics, and Cancer Research. This term I'm doing the Cancer and Society. So it's been very informative and very eye-opening for me. And this field, as this field is very new here in the Solomon Islands. So it's been great. I thank the tutors as well for being very helpful in this course. And also it also provides new opportunities for research. In the Solomons, there's not much research done. So after completing the cancer research, I now can see that there's a lot of room for research here in the Solomon Islands. challenges for the course. I also have a bit of challenge going through the course as well. The internet is not so good, but slowly improving. Not only that, it's also very expensive actually. In the hospital, it's okay because in the hospital internet system. But when I go home, I have to pay my own bill to do my studies. And the other big challenge also is I'm doing the full-time work as the only oncology doctor, and not only that, the family obligations. So sometimes there's not enough time for studies. I'm the only one who drives in the family, so after work I have to run here and there, and before you know it, it's like almost middle of the night. So yeah, I'm learning new things. Also, things that I've never heard or seen before. So I've mentioned an example there. In one of the courses, cancer diagnostics, we have to write 2,500 words on how to explain to your patients what next generation sequencing is. And I've never heard and seen what this technology is, but it actually helps me to know what it is. So it's great. So, and also another problem is there's no oncologist here around the place to help me to mentor or supervise or run to get immediate help from. So, which is also a challenge, but I thank my tutors and Professor Desmond Yip as well. At times I emailed him for some advice as well. And the tutors here, of course, they're very helpful. So what are the ways forward in our oncology unit here? I mentioned a few: completion of the unit and the isolation room and the cupboard. Completing a master's of cancer science would be a great thing as well. We need more in-country trainings, outreach education and awareness, CT scan, which is available very soon. We need to fix our mammogram, organize overseas referral for radiation. We need to recruit a new doctor and new patient to do the registry as well, and focus on the multidisciplinary meetings as well. Thank you.
Thank you very much. And that was very informative and such a great partnership between you and Desmond, and such amazing work that you've done with such resourcefulness in the Solomon Islands. I think we only have time for one very brief question, of course not brief, but important question in terms of what the plans are for the partnership in the future. So maybe Dr. Soma, Professor Yip, would you be able to comment a little bit about that?
Andrew, you first.
Yeah, concerning the partnership, yeah, I think we've already come a long way. We would look forward to continue more on especially the mentoring part and assistance for the growing of the unit here in the Solomon Islands. So we would be very, it should continue in the long run, I would say.
I'll just echo Andrew's thoughts. I mean, they build a model that's hopefully sustainable, and the idea is to upskill their staff so they can train others, to expand the capacity of the unit. And what we really miss at the moment is the ability to do in-country visits. And unfortunately, the aid program in the South Pacific has been affected by the pandemic in order to try and keep the staff there safe. Because you've had very little COVID in your country, is it, compared to Fiji or PNG?
We don't have no community spread yet.
No. Yeah.
Yeah, and that's obviously pretty critical in terms of getting things under control. But it is frustrating to have that nice chemo preparation unit there all ready to go and not started, and your mammogram not fixed as well. Hopefully, once the pandemic is under better control, we'll be able to move forward with this fantastic program. So unfortunately, we will have to wrap up there. And that brings us to the end of today's Monday Lunch live stream webinar. I really want to thank Dr. Soma and Professor Yip for their participation, and the virtual audience for tuning in. A reminder that the VCCC Alliance has some interesting webinars coming up, and you can register via the VCCC Alliance events page for them. And also, today's webinar was recorded and will be available on the VCCC Alliance website shortly. So thank you very much.
Thank you.